Well, first of all, I want to thank Dr. Howell, as well as the committee, for inviting me to speak today with regard to systems redesigning, and care coordination, and especially to talk about the clinical nurse leader role. Today I will look at some of the national programs that are designed to measure and support care at the bedside, at the point of care, as well as describe initiatives that are currently in place or used across health systems, especially within the microsystem, to impact care and coordination of care. And then finally, I will discuss the role of the clinical nurse leader and their role specifically in that care coordination. I love this quote by Margaret Mead. Oops, is that all right? Okay. I love this quote by Margaret Mead. Never doubt that a small group of thoughtful, committed citizens can change the world. In fact, it is the only thing it ever has. The change that is required in our health system, I think, is significant. In fact, I want to say, I think our healthcare system is broken. Think of these facts and figures. The Affordable Care Act is expected to add 32 million individuals to our health insurance rolls. Now, we see many of these patients right now, but we know that they do not seek health care except when there's an emergency. We also experienced in 2012 a 6 to 9% increase in our health care premiums. Currently, we have our healthcare expenditures at 18% of our gross national product in the U.S., expected to rise to 20% by 2020. And if we look at healthcare disparities, we, at this point in time, right now in 2012, experience age, ethnicity, and cultural disparities. We know, for example, that a 65-year-old African-American woman who's had a breast cancer and a lump removed, but who's had most of her breast tissue conserved, will not be offered radiotherapy as often as her counterpart, a white woman over the age of 65. We know that if you are 75 and experience chronic leukemia, that you will not be offered the full spectrum of effective medications, as if you were 50. We know between 2005 and 2009, the median wealth of Hispanic households dropped 66%. Oh, and African Americans' median dropped 55. The white American, non-Hispanic, dropped 16%. We have currently experienced the largest wealth disparity in the U.S., according to the Census Bureau. Our health system is ranked 37th in the world, and our health system ranks next to last or last on these dimensions internationally: quality, access, efficiency, and equity. However, as talked about by our two previous speakers, and I think by our speakers to come, we have great hope, because I believe all of you, our alumni, our associates, are ready to meet this challenge of making change in our health systems. And so what I'm about to talk about today, and what I want to focus on, is what programs currently exist in this country, what we need to do to redesign our systems, and what are some of the roles that will help us get there. I'm very, very proud of the Institute for Healthcare Improvement. This program, this national program, was developed in 1991 by Donald Burrick and a group of leaders who were committed to change healthcare, to eliminate error, waste, and to decrease cost. Their very first decade really focused a lot on implementing best practices throughout the country. And their second decade has experienced a focus on innovation, research and development, and redesigning processes, which is the focus of what I'm talking about. In 2003, they initiated the TCAB. Now, how many of you are familiar with the TCAB, even know what that means? Raise your hands. A few. Because we have a few organizations in town who actually took on this. TCAB is Transforming Care at the Bedside. And what the IHI did, in conjunction with the Robert Woods Johnson, is they actually implemented an initiative to create a framework to change care in medical surgical units throughout the country, especially on 4 categories: safety, reliability, the care team vitality, and patient-centeredness. In addition, in 2004, they implemented the 100,000 campaign, Save Lives campaign, and in 2006 to 2008, the 5 million Save Lives campaign. And in this initiative, they actually focused on organizations to gather their commitment to decrease medical error and decrease harm. And to this date, over 4,000 hospitals have joined that effort to make significant strides. In 2008, the IHI opened a open school. And what this is, and it's open to all students, all faculty, free of charge. There is a fee for people that are just health professionals, a small fee, but you can go on and obtain education on quality improvement and safety initiatives online through modules that are put together. And currently, the IHI has a tremendous global influence, working with TB in Peru on tuberculosis, in Malawi on newborn fatality rates, and AIDS in South Africa. And so there, as a national program, it has influenced our care tremendously. However, I have to say that these reports from the Institute of Medicine, have accelerated this movement, especially in redesigning care. In every one of these reports, there is a focus on the impact and the importance of redesigning care. To Err is Human is the most significant report that moved us forward and created the catalyst that made us confront our own issues in healthcare with safety. In that report, of course, they cited that there were over 100,000 lives lost a year due to medical error. The Crossing the Quality Chasm, I like to frame that as they provided the recommendations for us to change. And if you read back and look at that today, you'll see that many of the things that you're doing right now in your organizations, it's almost like a blueprint from the Quality Chasm. In keeping patients safe, transforming the work environment of nurses, it highlighted what changes do we need to make in nursing to impact care at the bedside, at the point of care, and to redesign our processes. And the Health Professions Education report, A Bridge to Quality, mandated that education get on board and that we train and educate our students in these same processes. And finally, in 2010, the Future of Nursing report, a phenomenal report that said there are a number of barriers that prevent nurses from being able to respond effectively to rapidly changing healthcare and situations that are occurring. And they said we must be able to practice at our full scope, that we must have higher levels of education, that we should be full partners in design, and that we need to have effective workforce planning and policy making to improve care. Another national program that is influential is the National Quality Forum, and probably most of the organizations that you work for or that you participate in some way belong to the National Quality Forum. And in this, they build consensus on national priorities and goals. They work in partnership. They endorse national consensus standards and promote the attainment of national goals. And so they are an accelerator in us moving forward. When we look at these national programs, our next phase is to really begin to move forward and say, how are we going to accomplish this? And my focus is that we need to redesign systems to help minimize error. So my framework of this is very much focused on quality and safety. But we must do this at the microsystem level. And the microsystem level is the smallest unit within your organization. It is where care is delivered. It's where we touch the patient. The term that we use and that you'll hear me say over and over is at the point of care. And most of these national programs that I just talked about recognize the need for this redesign. And most of their initiatives you can trace right back to that microsystem level. However, this is not enough. I am sad to say that in a study that was published in 2010 by Landrigan in the New England Journal of Medicine, they did a study, a recap of looking at, well, since they have implemented all these safety initiatives and quality initiatives, have they really saved lives? Have they decreased that number that was reported in 1999 of 100,000 deaths? Sadly enough, the finding was no. And this validated what many patient safety experts said, that harm resulting from medical care remains common. So what do we need to do? We need to focus not only on the system, the microsystem, we need to focus on you, the people. We need to create cultures of safety. We must get you to believe that we have to change. We must get you to believe that we shouldn't accept the ordinary, that we need to take that one step beyond. So I need to back off a little bit, and I want to ask a question, and I think many of you have seen this. In fact, I know Amy Abbott has, because we taught a patient safety course together, and her colleague and my colleague, Kevin Fuji, this is his slide. I was shocked when I saw it, but I want to ask a question. I want to raise a hand. How many think that a 1% level of error is acceptable? Raise your hand. Just a few, okay. So let's just do that. Now, most of you are wise and say, this is a trick question. I'm not going to raise my hand. Yeah. Well, it is. It is a trick question. So what does this mean in terms of other professions? That means 2 unsafe landings per day at O'Hare. It means 16,000 pieces of lost mail per hour. It means 32,000 bank checks deducted from the wrong account per hour. Now, would we stand for this? No, of course we would not stand for this. However, from 2006 to 2008, we had 1 million safety events among our Medicare patients, among 40 million acute care admissions. That's a 2.29% error rate. And of those patients who experienced that error, 1 in 10 had a chance of dying. And we continue to accept the unacceptable. How many have work with documents like this. When we look at pediatric trauma resuscitation, in a study that was done in 2006, we had a mean error of 5.9 errors per resuscitation. And in a landmark study that was done in critical care by the AHRQ, their major finding was patients face a significant risk for preventable adverse events and serious medical errors in hospital critical care units. In a study of patients admitted to intensive care, 20% had an adverse event. 45% of these events were preventable, and 90% of these incidents occurred during routine care. We accept the unacceptable. Okay, but there's hope. All right? Today at Creighton and throughout this country, we are promoting an education curriculum that infuses information to our students on patient safety, the science of safety. And we know, for example, that high reliable organizations are needed. The nuclear industry, NASA, and the airline industry are examples, and they are examples that we're extrapolating from in healthcare. We know that to achieve cultures of safety, we need to redesign our processes, we need to focus on the microsystem, but we need to focus on you, and we need to create cultures of safety. And in cultures of safety, we have open and honest disclosure, we have clear communication, we have blame-free environments, we have a collective responsibility. We do not point the fingers. We commit individually and collectively to personal accountability for safety. We act to preserve and enhance and communicate safety concerns. So if we see somebody doing something that is unsafe, we call them out on it. And we actively learn, adapt based on our errors. And I have no doubt in this particular community, as well as across the country, this is what organizations in healthcare are striving for. And to do that, we are focused on the microsystem. The microsystem will allow us, as Donald Burrick says, and this actually, a lot of this work came out of Dartmouth, and it is work that we teach in the graduate level and we teach in the undergraduate leadership level here at Creighton, and that is that where the patient meets the provider is key, and it's where care occurs. And it's where we need to focus. We have focused on the macro level for a long time, but we need to get down and focus on the micro. And so, major initiatives and projects that are taking place in this country, and this is what I am so proud of when I read this and have been part of some of this opportunity. And we here at Creighton have had some work done in some of these areas. But these are some of the areas that I want to focus on. The first one is Project Red. And Project Red really came about with this result. We had 39.5 million hospital discharges per year, and 19% of those discharges had some type of adverse event. And 20% of the Medicare patients were readmitted. So coming out of the AHRQ was a promotion of we need to do better discharge planning. And so Project Red is a focus on discharge planning. It's patient-centered, standardized approach to discharge planning. And here at Creighton, I am very proud. In fact, I should make Julie Z stand up. Zakowski, please stand up. She's our clinical nurse leader student in the program. And she was actually a main person, main RN, working with Project Red at Creighton that decreased congestive heart failure patient readmissions to 13.5%. Do you think that's the right figure, Julie? Is that about right? From 18%, I believe, and we actually won an award for that. So I was very, very proud to learn about this and to know about Project Red. Other programs that exist, we have Project Boost. This is developed by the Society of Hospital Medicine, and it was, again, a program to identify high-risk patients on admission and to target risk-specific interventions to help reduce their readmission rate. Other programs include the all-inclusive PACE program. I am really excited about this. This is coming to Nebraska. How many of you know about the PACE program? So I bet most of you can talk more about it than I can, but I have attended a program last year that was put on by our district, our Nebraska Nurses District, and I was so impressed with the results. This program is a team of health professionals that provide coordinated care for the elderly to help keep them in their home. And we, I believe, are starting a program here in Nebraska in January of 2013. Is that correct for those of you that, yep, I'm getting some shakes. So all of these initiatives have focused on processes that are at the point of care within the microsystem to impact change and are demonstrating phenomenal results. The final one that I want to spend extra time with is this new role. I was very fortunate. In fact, I have to say Dr. Howell dangled the carrot stick in front of me when she offered a position for me in 2005 and told me that I would have an opportunity to work on the curriculum for the clinical nurse leader. As the director of nursing out at Fremont Area Medical Center, I had followed the progress of the clinical nurse leader. And in my role, if I would have remained there, I had wanted to implement that role at Fremont. I believe, I have never in my 30 plus years of nursing been so excited about a role in nursing and the ability to impact our processes at the bedside or at the point of care. What happened is that academic partners throughout the country, as well as health systems, leaders in the health system, came together early in 2000, 2002, 2003, 2004, and they were responding to the Institute of Medicine reports that said, we need to revamp nursing, we need to revamp the education, we need to impact our healthcare system and create a role that can manage the complexity that's needed at the bedside. And through this discussion, and it was a national arena discussion across the country, many, many different meetings of various professionals, interdisciplinary professionals, they made the decision to create a new role in nursing. In fact, the first one, as Dr. Howell said, in 40 years, and that is the clinical nurse leader. And the clinical nurse leader is a master's degree nurse who is an advanced generalist, but who practices at the point of care. And that point of care is just not in acute care. That point of care can be in long-term care, it can be in home health, it can be in OR, it can be across any system, but they practice at that microsystem level. How is it differentiated? How is this role differentiated from the CNS or the MP? There is no specialized role focus, so there's not the advanced classes in oncology or gerontology or cardiology. The courses and the advancement that they receive is in quality improvement and safety and coordination of care. And they manage the outcomes, both clinical, safety, cost, and innovation outcomes at that point of care. They work with a multidisciplinary team. They're called lateral integrators. That means they're just great coordinators of care and communicators to all of the other disciplines that are impacting that particular patient in that particular microsystem or that group of patients. The daily schedule of a clinical nurse leader varies depending on the microsystem that that particular person is functioning in. Often they may round with a particular physician group, one physician group. They round with the nurses to find out who are the high-risk patients on this unit today. They understand how every single process of care impacts that outcome, and they manage those outcomes on a daily basis. They're the go-to person for anybody that wants to know what's happening on that unit. They are not a manager. They are not a charge nurse. They do not manage the staffing. They do not manage the operations of the unit. They manage the clinical care of the unit. And in the national clinical nurse leader conferences I have been attending since the very first one, especially in the VA system where the majority of these clinical nurse leaders are today, I have seen a wonderful representation from managers and clinical nurse specialists who are excited to have somebody to work with in this fashion on the units. So let's look at the outcomes though, because when they created this role, they said we cannot create a role and not from the very beginning start to look at what outcomes we are receiving. So in an article that was written by Hicks et al. In 2009, and this is from, they looked at several different areas, and one of them that I wanted to show you is, for example, they examined the intubated, the patient that had an ET tube, and looked at prophylaxis intervention, pre-CNL and post-CNL. And you can see they had a significant increase in that particular unit. In another example, this is an outpatient GI lab where there was lost dollars, truthfully, and probably lost care being provided for patients that canceled their GI procedure. They went from a 30% cancellation rate down to a 20%. This is within a 6-month time period. And in the most recent study that was done in 2012 by Bender, they actually used Press-Ganey satisfaction scores, and they were able to, over a 1-year time, find that in the units with CNLs, they found a significant decrease or increase in patient satisfaction with admission, patient satisfaction with nursing, that the patients were more satisfied with their skill of the registered nurse, that they felt they were better informed and kept informed, that there was attention to their request and attention to special needs. And in a study that I don't have listed here is by Karen Ott, who's the director of clinical practice at the VA. And in her article, they did a study with canceled surgeries and found that in 2006, they had 638 canceled surgeries out of 4,430 scheduled. And when they implemented the CNL role within that area, with that focus, with what that was just one of the projects that CNL focused on, that they were able to decrease their cancellation rate to 11.4%, a cost avoidance of $462,000. So I encourage you to think about this role and to, especially for your health system, if you are a leader, to think about this role as a viable role. If you are a student, this is a viable option for you to remain at the bedside, but accelerate and advance your career. I'm very excited about this role. We are in 2012. We've had this role since 2007. And the VA system, currently we have Julie Zolkowski at Creighton, who will be graduating this year. We have 2 students enrolled from the VA. And we are probably in the Midwest, the slowest growing area with CNLs. Currently, there are 1,600 certified CNLs in the country, and most of them practice on the East and West Coast. And so I look forward, and I have great hope that this role will be significant in the future. And I thank you very much.